Hello, everybody, ladies and gentlemen. Good afternoon and good morning for those that are joining us from the US. Thank you very much for attending this webinar, and thank you, Roderick and Nigel, for being here. For those that have not used Zoom before, you see that there's a Q&A session at the bottom of your screen, and that's your way to effectively ask questions throughout the webinar. With Zoom, you are automatically muted, and don't worry about your video. We cannot see you. That's also off. Therefore, your way to ask us question is through the Q&A session. The webinar is recorded. Therefore, if you're missing some parts, do not worry, because we're going to circulate it later on. And also, if you are unable to join us by video, so you joined us by telephone, please do send your questions to info@steps-charity.org.uk. We're just going to wait a few minutes to allow other participants to join in. And may I ask those that are online, if you could please send a message through the Q&A section so that I know that it's working fine, please. Oh, I can see them coming in. Thank you very much. That's working all fine. Perfect, thank you. Okay, I think we can go ahead and start the webinar. My name is Loredana Gwitch-Wyatt, and I'm Managing Director of STEPS Charity Worldwide.
Okay, hello, I'm Nigel Kiely. I'm a children's orthopaedic surgeon, and I work at the Robert Jones and Agnes Hunt's Orthopaedic Hospital in Oswald Street, Shropshire, UK.
And I'm Rod Duncan. I'm a paediatric orthopaedic surgeon in Glasgow, Scotland, and I'm very happy to join this webinar.
Thank you very much, both of you. Would it be possible to start with a summary of what you deem to be the key recommendations from BISCUS and the BOA Association?
Okay, shall I go with that one? So we've had some recommendations during this difficult time, and it is a very challenging time for all of us. If we think about DDH in babies, we are continuing to arrange ultrasound scans for children who have found to have an abnormality on their neonatal check. So if the hip feels unstable or there's limited movement of the hip, and we'll be arranging an ultrasound scan for those babies. And then if treatment's required with a harness, then that's something we can continue to do. The main change is that children who have risk factors for DDH, such as breech or family history, we're not able to arrange a scan at normal time as we would within 6 weeks. So we'll be looking to review those children at a later date, depending on when the situation changes. Rod, is there anything you want to add to that?
No, that's, I think the important thing to point out is that those are the general principles of how things are going to be managed during the COVID pandemic. But every area is doing things slightly differently as far as timings of scans, arrangements for following up children. And I think it's really important that people have a close link with their own team so that they know what's happening in their own area. And what's happening in one part of the country may be completely different to what's happening in another part of the country, and that just reflects the different availability of resources, the number of people at work, etc., etc. So I think the key message to get over for the whole webinar really is to make sure you've got contact numbers with your own team, for your own team, so you know what's going on locally.
Yeah, I think that's an important point. There is a lot of variation, and different teams will be arranging contacts within different ways, whether by email or telephone or whatever it might be.
Yeah.
And I guess it brings us to the first question that we've been asked with regards to follow-up appointments. So those children that should be seen later on in April or May or June, a question that has been asked is, will those appointments still go ahead, or will they be cancelled?
So if I'll tell you one, I think it depends a little bit on the situation. I think if your child is already in a harness, for example, and being treated, then I imagine your team will arrange some further scans so you know when the treatment's completed. If your child's had, for example, surgical treatment and you're waiting for a further X-ray, then we'll have to defer the X-ray until the COVID crisis is over and it's safe to bring you to hospital.
Thank you. And with regards to treatment, would you be able to explain the difference between the children that will be scanned and those that potentially will be delayed? For example, one question that has come in is related to a baby that has risk factors present, and they're wondering whether they will receive an ultrasound.
My understanding is that most units will have an arrangement for these scans to be done at some point. Again, it'll vary tremendously from one part of the country to another, but in our area, what we're doing is the paediatricians are maintaining a list of children with risk factors and will arrange for these kids to be scanned at some point. So there'll be the appointment for the scan will be on hold in the meantime, but that may be different in other parts of the country. So they will get their scans, but not perhaps within the time scale that is normally followed.
Yeah, we're doing similar things. So I'm arranging a scan for a few months' time, but again, we just don't know what the situation will be with the COVID crisis. So it really depends on how that pans out.
Thank you. And with regards to obviously safety in mind and trying to avoid contracting potentially COVID-19, are there any restrictions as to how many parents are allowed to attend the scans? As far as you know, our hospital restricting just one parent to allow to go with the child.
We've been doing that. We've been screening patients and families when they come in. We're taking our scans in a separate unit within our hospital, again, to try and restrict contact, and we're asking one parent to come in at a time.
Yeah, us too.
Thank you. One area also that is quite key to discuss is related to those children that have been fitted with a Pavlik harness. And one question that has come in is, what if there are problems with the Pavlik harness and I can't get through to my medical team? Basically, they're asking, should I remove the harness? And if I do so, what are the long-term consequences of me removing the harness?
Yeah, that's a really difficult problem. But I would hope that you would have a reliable way of contacting your local team to, because taking off the harness yourself at home is all very well if you know how to put it back on again. But the problem with Pavliks is you have to put them on really quite precisely. If you've been shown how to do them, if the harness has been marked, so the straps are the correct length and stuff, then and you know what you're doing, that's fine. But if you don't, really taking the harness off and then just yourself is generally not advisable. I mean, these harnesses, one of my colleagues actually used to treat his Pavlik harness protocol was actually to leave the harness on the whole time. So he would leave it weeks and weeks between ultrasound scans and leave the harness on, so it wasn't getting changed regularly and the child was just being topped and tailed. And that's a very acceptable way of doing it. Other people do harnesses are taken off and the baby cleaned every week. It's all very different, but you can leave them on for quite a long period of time. But the key is to make sure you have a contact number for your local team, so you can phone them, so you can discuss with them. And if people aren't at work, they hopefully will get back to you and let you know what's what. I mean, one of the changes that Nigel alluded to earlier on was the fact that we're much more used to telephoning patients than we used to. We're all running telephone clinics. We're happy to speak to people. Sometimes we can arrange video conferences with video calls with families, and that can be very useful too. So, but the key thing is to make sure you've got a contact with your reliable contact number for your local team.
Yeah, I would agree with that. And I think particularly with small babies as well, they grow so rapidly, the harness can become tight, so it should be checked regularly. So if you do have any concerns, then get in touch with your team. And there are different reasons for the harness being on. So your team may bring you back in to check it. They may decide that you could take it off at home if you're getting towards the end of treatment. So it will vary.
Yeah.
Thank you. And with regards to if for whatever reason an RNS is not fitted, what would potentially be, what are the long-term consequences?
So I think it depends on, again, sorry, being very vague, but it depends on what you're being treated for. So if you're being treated for a hip that's shallow, that's dysplastic, the long-term consequences might mean you might need some further brace treatments a few months down the line. If the hip is dislocated and we don't treat it for whatever reason, then that might mean more interventional treatment in the future.
Thank you. Talking about potentially having difficulties reaching the medical team, as we said, the important part is that families and parents have to reach out to their medical teams and be certain that they have their contact details. But one of the questions that has come in is basically, what if I choose to go privately and maybe seek to find a health professional that would scan my child privately or continue with the treatment this way? What would be your point of view on this?
My impression is that the private sector is not really functioning at the moment, but so I'm not really sure that provides a satisfactory avenue for treatment. I mean, there's various ways of contacting local teams through the hospital switchboard, through going down to the secretaries of the pediatric orthopedic department. I mean, I wouldn't recommend ringing the on-call orthopedic registrar, but you know, if desperate times that's what's required, then I didn't recommend it, but it's a possibility.
I wouldn't recommend taking your child to the accident emergency department, because that will be at this time inappropriate.
Correct.
Because one, they're overburdened, and two, you'll meet with someone who probably won't have experience of treating children in a Pavlik harness. So it's best to try and get in touch with your team.
And with regards to A&E, actually there's a question that just came in. If something goes wrong, we're talking about children in a speaker cast, and for whatever reason the cast has become too tight, there's a rash, what do you suggest parents do? Because obviously we're trying to discourage them to go to A&E with COVID-19, but what should they do?
I think the same thing. I think contact your local team. Unless your child is acutely unwell, I mean, if they've got a temperature or they're vomiting or they appear sick, then that's a different matter. But if it's a problem with the cast is a bit tight or there's irritation, then contact your local orthopedic team. Again, the people in A&E won't have experience of spica cast. Yeah. They won't be able to help you that much.
Yeah, and I would strongly agree with that. The A&E team are really good at lots of things, but really their experience of looking after kids with both club feet and DDH, Pavliks, spikers, yeah. That's a highly specialist field in which they haven't got the expertise.
And children with that are in a spica cast, is it fair to assume that obviously they will be monitoring if the cast will come to tight? Obviously, those type of reviews will carry on as normal.
Yes, I mean, sure. Go ahead, Rob.
I would expect the local team should know which children they have in casts, and will be able to get in touch with these families to check on them using telephone interviews or to bring them up to emergency plaster clinics or things like that. So hopefully people will not be left out in the cold.
No, I think we're doing the same thing. We're not leaving children in the cast longer than necessary. We'll arrange to take them off. There may be some special precautions undertaken when you remove the cast because of using the saw, but we wouldn't want to leave children in for an excessively long time. You can with a spiker, you can have a spiker on a few weeks more than planned if circumstances dictate, but that's not going to do any harm on its own.
Agreed.
Thank you. And moving on to children that were scheduled to have an operation and now unfortunately the surgery has been moved. Key question that has been asked is what's the adverse impact on my child's long-term ability to walk, given that the surgery now has been postponed, and what kind of activity should they not be doing?
So I would normally advise parents of the child with an older child with a dislocated hip that whatever they do won't do any harm. It won't make it any better or worse. So if your child has a dislocated hip and surgery's been deferred, you can do normal activities. You know, if the child's at walking age, they can walk, run, play, whatever it is you want to do. So there's no special restrictions required.
Yep, agreed. And at the end of the day, it shouldn't have much of a difference. The treatment the child gets should not have much of an impact on the child's ability to walk long term. Obviously, there are some children with dislocated hips who have other things wrong with them, and that maybe doesn't apply to them. Children who've got neurological, neuromuscular conditions and things like that. But generally, for your the standard presentation of an otherwise completely fit and healthy child with a dislocated hip, a delay of a few months probably won't make a huge amount of difference to their walking ability. It may alter the treatment that's required, and I think we have to accept that some children who may have a closed reduction where the hip is just simply placed with it and a cast put on, that might not work if there's a significant delay in treatment, and I think we have to be realistic about that. But I suspect that a few months delay will not make a huge amount of difference. In fact, there was a trend several years ago for waiting for children to reach a certain age before they were deemed fit for a closed reduction, waiting for the hip to become mature enough. So there has been a fashion in the past for leaving hips for a while, leaving hips dislocated until the child's a certain age. So the delay is probably not going to be that significant.
And around the country, there's quite a large variation in the way people treat dislocated hips in older children. So it's therefore difficult to say whether the delay does make any big difference to the outcome.
Thank you. And we had an interesting question with regards to equipment, and specifically for those children that have had a surgery and they have to come home, and obviously if they can't get a car seat, an adequate car seat, I mean, how will they be able to go back home?
Well, hopefully you would have to have hospital transport if you can't get a car seat. Save lives, so we never compromise on car seats. So if you can't get home in a car, then it'd be hospital transport, which might be more difficult during this time.
Yeah, we are not operating on children at all at the moment. So and we're very lucky in that we supply car seats to our own families.
Yeah, I suppose the only children in Spiker at the moment actually would be if you're right. We're not operating on anyone with at the moment, but children have had a fracture of their thigh bone, their femur. They may be treated in the Spiker, so that might be the only scenario.
Yeah.
Yes, it is. I believe this question was more related to a child in a Spiker cats that had a fracture. Obviously, that will carry on.
Yeah.
And we also have a question in terms of pain management, and what would you suggest in the case where there are issues with the cast? What would you suggest that the child will take? And is there anything else if they can't, given that some families are struggling to find actually the necessary medicine in the pharmacies at the moment?
So I think if your child's in a cast because they've been treated for DDH by surgery, a few weeks or months ago, you shouldn't be in pain. So if they're in pain, you have to look for other reasons why. And again, that may mean contacting your orthopedic team to make sure there's not a problem with the cast, or making sure there's nothing else wrong with the child that's causing pain. But by and large, children should be quite comfortable in a cast.
Okay, thank you. And I have received also a question not related, not necessarily to COVID-19, but in terms of activities and whether a child that is diagnosed with DDH, whether they should be, whether we should promote sport activities and whether they should be active, especially whether they should be told not to use trampolines effectively as well, and what activity they should actually do, whether one should prefer swimming towards another sport activity.
before, it depends whether the child's before or after treatment. As Nigel said earlier on, before treatment, we don't place any restrictions on the children at all. It's important to get their muscles, bones, and everything strong, and not to interfere with their developmental milestones. After treatment, when they've rehabilitated from the surgery themselves, when the hip's mobile again, I don't place any restrictions at all on these children. Because the whole point of doing the operation is that you allow these children to get out and go and do normal stuff normally. That's what we want kids to do. We don't want kids being restricted at all. We want them out doing the same as everybody else.
However, at the moment, don't use trampolines because we're concerned about children injuring themselves and being taken to the hospital with fractures. So I think, unfortunately, at the moment, there's got to be some restriction. And swimming, unless you've got a pool in your back garden, you can't go swimming either.
You can keep children off trampolines, would be a miracle.
Yes, yeah.
Thank you. And there's a question related to a late diagnosis of DDH, in that if they see signs of DDH, what should they do? Should they contact the GP? Should they just wait until COVID-19 is over?
Well, I suppose if you'd want to know, if it's a parent noticing something, you want to know what the diagnosis is. But practically speaking, if it's an older child and we diagnose a dislocated hip now, we're not going to do anything until the crisis is over. So I'd be concerned if the child had pain, stiff hip, they were unwell, which would suggest another diagnosis maybe. But if there's any concern that it's a dislocated hip, you want to get the diagnosis made as soon as you can. But practically, we're not going to treat it at this stage. And this is for older children, sort of 5-6 months plus.
Thank you. That's it from our side in terms of Q&A. And I don't know if anybody of you out there have questions that they would like to have answered. I believe we have gone through all of the questions from the attendees. I think there's a question, sorry, that has come in, which relates to, with the delay, is there an upper age limit for pelvic osteotomy in older children?
An upper age limit. I mean, we're not going to be, any delays in surgery are only going to be a matter of weeks and months, not years. So I think I would be very surprised if there was other than perhaps more children requiring open reduction than closed reduction with short delays. I think once you reach the stage of needing an open reduction plus or minus other bony work, I think a delay of a few months is not going to make a significant difference to what's done. So if your child is needing an open reduction and a pelvic osteotomy, for example, then I think it's extremely unlikely that with a delay of a couple of months that that operative plan will need to change.
And there are lots of different types of pelvic osteotomy, and we do pelvic osteotomies anywhere from 18 months up until adults. So it depends, on your particular circumstances.
Yeah.
But I agree, a few months delay is not going to make a big difference in that situation.
And one last question, which I think it's for parents are there. How long do you think it will be until operation will start again, and is there going to be a backlog?
Yes, there's going to be a backlog, and no, we don't know how long it's going to go on for. It's impossible to say. I mean, these are circumstances we've never ever come across before.
Yeah, I agree with that. We don't know. Yeah, I hope not.
Thank you. And I guess the key message that we also want to give to parents and our attendees is to ensure that you provide your contact details to your medical team, that if you have concern that you need to contact them first. In just urgent situations, as you've heard, go to A&E, but first you should absolutely contact your team. And I guess key is that every child is different, and every child has a different story, different type of condition, different phase of treatment, and therefore Try to avoid reading general advice or advice that maybe you see from other groups, specifically on Facebook or our famous Dr. Google. What works for one child doesn't necessarily work for your child, and I think that's quite a key message that we want to give to all of you.
Yes,
Any remarks from you, Nigel or Roderick?
No, I agree. I mean, it's DDH is a very wide spectrum of conditions, and it depends on how severe the hip problem is and the age of the child. So you really got to take care of every individual.
Yeah, absolutely. And the local team are the key.
Yes, yeah.
Perfect. Thank you very much for both of you for your time.
Thank you.
During this
Thank you.
difficult moment.
Thank you. It's been a pleasure.
Thank you, everybody, to the to those that have participated. If you have further questions, please do submit them to info@steps-charity.org.uk, and please do contact us if you need to be put in contact with a family that is going through the same, or if there are questions that you would like to submit to our panelists. Thank you very much, everybody, and bye-bye.